So I'm going to talk about how to do a lumbar epidural. I'll mainly concentrate my talk around the transforaminal epidural because that is the procedure that is the most rewarding procedure that we see once it's done on the patient. So the rationale of giving steroids at the target level uh, of the disc prolapse is to reduce the inflammation around the nerve. And that is what gives us good results. So when we talk about fluoroscopic guided blocks, the aim is to deposit the steroid and the medicine in the anterior epidural space. So when we are talking about the anterior epidural space, we have two approaches mainly, transforaminal or the selective nerve route. So now we know that the fascial sheath around the nerve that is directly communicating with the dura mater, which goes into the epidural space retrogradely. So people use these two terms interchangeably, transforaminal or selective nerve route. But when you are medially and when you are within the intervertebral foramen, you call it a transforaminal. So you get a nerve root spread and an epidural spread of contrast. And if you are laterally, that is near the exiting root, and you're outside the intervertebral foramen, it is more of a selective nerve root block. So to do this procedure, we need the patient in prone position. Better to keep a pillow under the lumbar spine. So it opens up the lumbar spine. So it's better visualized. So you need a continuous X-ray facility, C-arm facility, some basic monitoring, like at least a pulse oximeter on the patient, and the C-arm facility with a good technician who can understand what kind of views you need. Mainly you need oblique views and you need a caudate and a cranial tilt here. So the drugs that you require here would be some syringes, local anesthetic, steroid. I use triamcinolone, but there's a lot of controversy about particulate versus non-particulate steroid. And then a 3.5-inch spinal needle, a 25 or a 22 gauge, whatever you're comfortable with. And contrast, of course. So the way I do it is I have in the 10 cc, I always take local anesthetic for the skin. In the 5 cc syringe, it's always the steroid, and the contrast is always in the 2 cc syringe. So I know what I'm doing, because you cannot label these drugs. So firstly, when you have taken the patient on table, first you do a straight AP image of the spine. You match the level that you want to target with the MRI, and to keep the MRI films in the room, and you match the target level which you are looking at. And so then we meet our friend, the Scotty dog, and we do oblique image, 15 to 20 degree oblique image, and then you need to square the vertebra here. So we look at the Scotty dog. We all know this from our medical college days. So there are two approaches now mainly to the transforaminal space. One is the safe triangle approach, which is followed routinely, but however, it isn't safe anymore. So the safe triangle is said when you are subpedicular. You are right below the chin or the neck of the Scotty dog. And the Camden's approach is when you are just next to this, you're in the inferior part of the foramen, and you are next to the superior articular process of the inferior vertebra. So in lateral imaging, this is the safe approach, and that is the Camden's approach. And your needle position, your final needle position on lateral screening, here it would be superiorly, and inferiorly it would be when you're doing the Camden's approach. So I'll show you on the left L4 Camden's approach here. So you mark the skin at the L4 level, then you give local anesthetic, and this is followed by placing the needle. So this is going too fast. Can you stop this? Sorry. Yeah, so sorry. So you take the spinal needle and you square the vertebrae, of course, the inferior end plate here, and you using coaxial imaging, that means you follow the beam of the C-arm. In oblique C-arm position, you follow the beam of the C-arm so that your needle is visible only as a small dot here. So and now I'm going to be doing the L5 vertebra here, the L5 transforaminal. So for the L5, I've done the safe triangle approach. So again, you square the vertebra in oblique position, 15 to 20 degree oblique to the ipsilateral side, square the vertebra, square the end plate, so that you're not in the superior and part, you're properly in the superior part of the aspect of the foramen. Then using the spinal needle, Again, using coaxial imaging, direct the needle towards the superior aspect of the foramen. And while you're going lateral, just before you go lateral, you can do a straight AP image to see how far deep you are. You can see it even on an AP image that you are not yet, the L4 is not yet into the foramen, but the L5 definitely is. So then you see so the direction is seen by the oblique imaging and depth you see by lateral imaging. So you take a lateral image and like I said, the L4 isn't too far. Now, this is the Camden's approach, the L4, whereas the L5 have done the safe triangle approach. So it's a bit tight here because we call the L5 the safe. It's called because you are going to be in the nerve. You're not going to be in the nerve. That's what it is seen. But however, now Camden's approach has come into vogue because you would be avoiding the vessels which are present in the superior part of the foramen. So here we are little too shallow. So when you go a little deep, the only problem here is you could be, if you go slightly deep, you could be in the disc. Okay, but when we think that we could be just before the disc, what we do is we put contrast. So we see the contrast spread here in the L4 and L5. So on AP imaging, first you do lateral imaging to see the contrast, then AP image. So the contrast should be seen as these nice two parallel lines. So which tells you that the contrast has spread circumferentially around the nerve. So like I said, if when you do a transforaminal, it is supposed to spread retrogradely into the epidural space as well as into the nerve root. So if anybody's interested in this S1, S1 is slightly different. Here you do not square the vertebrae. Here I've already done a right L5 and I'm doing the S1 here. So you see this figure of 8 of the two sacral foramen, the anterior and the posterior sacral foramen. So that's what you see. And then you try to go, you give local anesthetic there and you go from the lower foramen towards the upper foramen. And then once you are, when you know that you are 3 to 4 centimeters deep, you do lateral imaging to make sure you're inside the foramen, give the contrast and see the contrast spread. So this is the interlaminar epidural. It's restricted for certain cases, but if you know it, it's a good thing to know. There are some studies to say now that if you are in the lateral recess, ipsilaterally into the lateral recess, the dye spread is quite good and it does go into the anterior epidural space. But then we always follow that the drug will follow the path of least resistance. So we do not do these, we usually do transforaminal epidurals wherever possible. Caudal epidural, you're starting from the sacral hiatus. Again, dye spread, but you need huge volumes, and the drug is meant to be in the anterior epidural space, but because of the distance, you need higher volumes. So we use steroids because we know we'll not get into so much of pharmacology of it. But there is a lot of controversy between methylpred, triamcinolone, and dexamethasone. Triamcinolone is deposteroid and it is particulate. So there is some, if it goes intravascularly, you have to be careful about it. And if and then saline and local anesthetic is used as a vehicle along with the steroid. So use dilute local anesthetics like bupivacaine 0.1% or ropivacaine 0.15%. So 1 in 5 dilutions so that your patient is not very numb after the procedure. Hyaluronidase, I use it for post-op patients. It doesn't cause adhesiolysis, but it helps in better spread of the drug. And for adhesiolysis, hypertonic saline has been used. So now something about the safety and the precautions. Follow strict asepsis, blood sugars. Don't do it with very high blood sugar level. My cutoff is around 180 to 200 because there are studies to say that the post-lunch blood sugar increases by 50 to 75 milligrams per deciliter after a steroid injection. So if you're starting with 250, you'll land up with 325, which is not good. And then blood thinners, depending on the duration, depending on the drug, you have to stop these because you are near the central neuraxial space. And triamcinolone, there are studies to say people have given 5, 10, 20, 40 mg at one level, but 10 mg is what is enough. And the total dose in one sitting is 80 mg. It should not be given. It should be given at an interval of 6 to 8 weeks in any part of the body. Patients come with shoulder pain and back pain, and also just make sure that once given steroid, it should not be repeated again, and it has a depot effect. It stays in the body. It stays at the target level. So when you see runoff, smell that slide. So when you see runoff of contrast, you should worry about it, and you should do continuous live fluoroscopy imaging at that time, and just so that you are avoiding this radiculomedullary artery, that is the artery of Adam-Quist. So usually it arises at T8 to T9, but it can be as low as L5. Avoid, just make sure that the patient doesn't have any allergy, especially to the contrast. Renal failure patients where the creatinine is high, be careful when you're giving contrast. Although we use very small amount of contrast, just 1 to 2 ml, but you can go lower with them. And basic monitoring you need, because the patients might be very anxious and in pain. They could land up with a vasovagal. And small chance for post-dural puncture headache after this transforaminal. Thank you.